Finals SAQ61 Tracheostomy. Question 1. You have been called urgently to attend a ventilated patient on ICU who has become acutely agitated, hypertensive, and profoundly hypoxic. A percutaneous tracheostomy was performed 18 hours ago and is being weaned from ventilatory support. A. List the possible causes for this patient's acute hypoxia. Possible patient problems include pneumothorax, hemothorax, pneumomediastinum, hemomediastinum, surgical emphysema, atelectasis, inadequate ventilation due to overly rapid weaning and aspiration. Equipment problems could be tracheostomy tube blocked with secretions or blood, dislodged tracheostomy tube, cuff puncture or deflation or herniation over end of tube, cuff inflated with speaking valve in situ, ventilator circuit blockage or disconnection, inappropriate ventilator settings, inappropriately low fraction of inspired oxygen. B. What clinical features support an airway problem? This includes acute desaturation, paradoxical chest movement, increased work of breathing and tachypnea, absence or abnormal morphology of capnography trace, hypertension, subcutaneous emphysema, neck swelling, and in an awake patient, the patient may complain difficulty in breathing, severe agitation and restlessness. Signs suggestive of displaced tracheostomy tube may be present, such as the above-mentioned signs: obvious incorrect placement of tracheostomy, patient suddenly being able to talk, frequent requirement of inflation of cuff to prevent air leak, pain at tracheostomy site, suction catheter not passing easily into the trachea, changing or inadequate or absent capnograph trace, and aspiration. C. How would you manage an airway problem in this patient? This is a critical incident. Call for help from senior anesthetic, ENT and resuscitation team according to local protocols and call for difficult airway trolley. Provide 100% oxygen via Mapleson C to tracheostomy and over the mouth. Stop nasogastric feed. Assess chest and Mapleson C back movement, capnography waveform, and for obvious tube dislodgement, secretions, blood, neck swelling and surgical emphysema. Inflate the tracheostomy cuff if it still appears to be in place and carefully assess breathing. In the absence of breathing or a normal capnography trace, attempt 2 ventilated breaths. If unsuccessful, remove inner tube if present and pass suction tube through the tracheostomy to clear any blood or secretions causing blockage. If unsuccessful, deflate the cuff and observe whether the patient is now able to breathe around the tracheostomy. Consider re-inflating if the condition improves, as the cuff may have been herniated over the end of the tube. If there is no improvement, remove the tracheostomy tube, occlude the stoma with gauze and occlusive dressing, start 2-person face mask oxygenation with oropharyngeal airway, either spontaneously or manually assisted ventilation. Attempt to ventilate orally following the DUS algorithm. If successful and oxygen saturations are improving, continue while checking notes for previous ease of laryngoscopy, indication for percutaneous tracheostomy, etc. Ensure emergency drugs, difficult airway trolley and senior help have arrived before attempting oral intubation. If unsuccessful, try oral intubation. If cannot ventilate and cannot intubate situation develops, try supraglottic airway device, ventilation via stoma using a small mask, or intubation of the stoma with a size 6 ETT. Once airway managed appropriately, move on to assess and manage cardiorespiratory stability. Bonus question: if the patient has had a laryngectomy, how would your immediate management differ? A patient with a laryngectomy has no connection between their oropharynx and their trachea, therefore all attempts to ventilate or intubate the patient must focus on the stoma. 76.6% pass rate. This is one of the many questions that are based on the findings from NAP4. Tracheostomy dislodgement on ICU and failure to recognize or manage this eventually contributed to ICU airway-related deaths reported to NAP4. Of 14 patients who had dislodgements, 7 died and 4 had hypoxic brain injury. NAP4 therefore produced a flowchart for management of this situation, and many hospitals will have had adapted these for their own use. Question 2. What are the indications for and possible contraindications to elective percutaneous tracheostomy? Possible indications include for long-term ventilation or anticipated prolonged ventilatory weaning, to avoid complications of long-term tracheal intubation, such as vocal cord damage, laryngeal damage, and stenosis, to allow sedation to be stopped while invasive ventilation is ongoing, to facilitate patient communication if the patient is able via a speaking valve, to reduce dead space, to facilitate tracheal suctioning, and for airway protection in patients with poor airway reflexes, such as bulbar dysfunction. Contraindications to percutaneous tracheostomy includes unstable cervical spine, severe local infection of the anterior neck, and uncontrollable coagulopathy. Relative contraindications includes high PEEP or inspired oxygen requirements, features of difficult anatomy such as morbid obesity, short thick neck, reduced neck extension, excessive goiter, tracheal deviation, overlying blood vessels, and extensive scarring, for example due to radiotherapy or burns. Hemodynamic instability is also a relative contraindication. List the possible early and late patient complications of percutaneous tracheostomy. Early complications include that related to the airway, such as misplacement of tube, loss of airway, damage to the airway, such as fracture of tracheal rings, damage to posterior wall of the trachea and paratracheal placement, and airway obstruction, for example by blood, secretions, or foreign body. Respiratory complications include cardiopulmonary arrest, derecruitment, pneumothorax, pneumomediastinum, and subcutaneous emphysema. CVS side effects include bleeding from any vessels of the neck. Neurological complications include damage to recurrent laryngeal nerve. GI complications, esophageal perforation and tracheoesophageal fistula. Late complications include displacement or blocked tube causing loss of airway, for example by secretions, blood, or granuloma. This may lead to hypoxic brain damage and death. Tracheal erosion, ulceration, fistula formation, stenosis and scarring may occur. Tracheomalacia and subglottic stenosis may occur. Erosion into blood vessels may lead to bleeding, for example, tracheal innominate fistula formation. Localized infection or pneumonia, scarring and persistent stoma, and tracheoesophageal fistula may occur. This question had 79.4% pass rate. Additional questions. What are some common etiologies of upper airway obstruction? Supraglottic causes include epiglottitis, Ludwig's angina, retropharyngeal abscess, angioedema, chemical injury, neoplasm, foreign body aspiration, and extrinsic soft tissue compression. Infraglottic etiologies include chemical injury, neoplasm, foreign body aspiration, inflammation, infection, laryngotracheobronchitis, vocal cord paralysis, retropharyngeal abscess, papillomatosis, and trauma such as post-intubation stenosis. How do you approach and initiate management of an upper airway obstruction? First, interpret all available information to ascertain urgency. Is emergent airway indicated, or is there time for temporizing therapies? Hypoxic patients can be anxious, confused, and uncooperative. Assess the level of obstruction, the nature of the lesion, and ease of emergency front of neck access. A specific tissue diagnosis may enable pre-op shrinking of a lesion with antibiotics, steroids, chemotherapy, or radiotherapy if time allows. Although an emergent airway can be obtained via RSI, awake fiber optic intubation is in general a safer choice. Front of neck access is a life-saving emergent surgical airway. Determine the location of securing the airway. An experienced judgment must be made whether to risk airway stabilization in situ or transfer to a safer environment such as a dedicated equipped operation theatre. The patient's condition may deteriorate during transfer. Always give supplemental oxygen, such as via high-flow nasal cannula. Consider prophylactically assisting oxygenation via cricothyroid cannula, which may enable jet ventilation in a crisis. Temporizing therapy options include elevation of head of bed, heliox, inhaled racemic adrenaline, and IV corticosteroids. Airway options include awake techniques such as awake tracheal intubation and awake front of neck access. However, this is rarely easy in a distressed hypoxic patient. Next option is spontaneous ventilation under general anesthesia with slow incremental propofol TCI or inhalational induction, followed by laryngoscopy with video laryngoscopy or fiber optic bronchoscopy. Direct laryngoscopy is not the preferred option. Pass an appropriate tracheal tube or ventilation catheter once the patient is deep. Have a backup plan for apnea, especially if mask ventilation is difficult. Next option is TIVA with rapid neuromuscular blockade and rigid bronchoscopy. The bronchoscope establishes airway patency and acts as a dedicated airway, while assessment, ventilation, oxygenation, and surgery may take place. Next option is IV induction or TIVA, followed by rapid neuromuscular blockade, insertion of an anterior commissure laryngoscope as a conduit for a bougie, followed by intubation. Next option is TIVA, rapid neuromuscular blockade and insertion of a supraglottic airway device as a dedicated airway prior to definitive surgical management of the obstruction. This is indicated for fixed laryngeal or tracheal stenosis. Once airway is secured, evaluate etiology of obstruction, for example by CT imaging, laryngoscopy or bronchoscopy, to decide on management. What are some novel approaches to upper airway obstruction in a setting of lung cancer or extrinsic airway compression? This includes those with immediate response such as balloon dilation, stent placement, laser photoresection, electrocautery, argon plasma coagulation, and cryodebridement. Those with delayed response includes cryotherapy, brachytherapy, and external beam radiation. What airway strategies are available for lower airway obstruction? This includes awake tracheal intubation, fiber optic bronchoscope guided insertion of a long, narrow tracheal tube, jet ventilation, rigid bronchoscopy, and inhalational induction. What are the different techniques for a surgical airway? This includes standard surgical tracheostomy, percutaneous dilational tracheostomy, cricothyroidotomy, and mini tracheostomy. What is the role for ultrasound guidance in tracheostomy? This includes landmarking, structure identification, which is useful in obese or in patients with anomalous vascular structures, to measure tracheostomy tube size, to allow visualization of needle penetration through soft tissue structures, and as an adjunct to bronchoscopic guidance and current techniques. Limitations include paucity of RCTs and cannot evaluate posterior tracheal wall structures or possible injuries due to obscuration by intraluminal air. What are the advantages of tracheostomy over oral or nasotracheal intubation? This includes easier nursing management, facilitation of mouth care, reduced risk of vocal cord, mouth or nasal trauma, improved patient comfort, therefore reduced sedation requirements, aided bronchial suctioning, potential for eating and speaking, decreased incidence for sinusitis, assistance of weaning by 30 to 50% reduction in dead space and reduced airway resistance. Is emergency tracheostomy the surgical procedure of choice in patients with apnea and acute upper airway obstruction when intubation fails? No. Tracheostomy is acceptably safe when performed electively under controlled clinical conditions. However, risk of surgical complications increase significantly when done in an emergency situation. In comparison, the superficial location of the relatively avascular cricothyroid membrane allows for rapid, reliable insertion of an airway, thus providing the greatest likelihood of success. How is a cricothyrotomy performed and why is it not done electively? This is performed by using a scalpel to incise the overlying skin and stab the cricothyroid membrane. This membrane is approximately 1 to 2 centimeters below the thyroid notch, inferior to the vocal cords, within the subglottic larynx. The resultant opening into the airway is enlarged with a spreader, allowing placement of a tracheostomy tube. For percutaneous cricothyrotomy, commercially available instruments which are designed for emergency situations allow puncture of the membrane and introduction of an airway cannula in one maneuver. or following the placement of a bougie over which a cuffed tracheal tube can be placed. For long-term airway access, cricothyrotomy has higher incidence of delayed airway damage such as subglottic stenosis. What is the most lethal complication of tracheostomy in a perioperative period? Inadvertent decannulation of a tracheostomy tube prior to trach maturation, which can take up to 10 days. One must perform endotracheal or nasotracheal intubation emergently because the stomal tract is not yet mature. Attempts to reinsert the tracheostomy tube may result in the creation of a false tissue tract and the inability to ventilate the patient. Can patients with mechanical ventilation and tracheostomy speak? Yes. Patients with low to moderate minute ventilation requirements can whisper if the tracheostomy tube cuff is deflated to allow a small cuff leak. If patients have limited or no mechanical ventilatory requirements, a one-way speaking valve can be placed in line with the tracheostomy tube, allowing inhalation through the tracheostomy tube and exhalation past a deflated cuff through the native airway and vocal cords. The tracheostomy tube may need to be downsized to facilitate speech. Can patients with a tracheostomy eat? If the patient can tolerate the cuff being deflated, they can eat. The inflated cuff causes the posterior trachea to obstruct the esophagus, limiting ability to swallow and increasing aspiration risk. The tracheostomy can also prevent elevation of the larynx, which is necessary for swallowing, so a swallow evaluation is still recommended prior to advancing the diet. Why is it important to monitor intra-cuff pressures? Cuff pressures in excess of mucosal capillary perfusion pressures, usually 25 mmHg, can cause mucosal ischemia and resultant tracheostenosis. If a tracheal tube is underinflated, less than 18 mmHg, in a patient undergoing mechanical ventilation, the risk for aspiration and nosocomial pneumonia increase. Injury is less common with the use of low-pressure, high-volume cuffs. Intracuff pressures can vary with barometric pressure, hence monitoring for elevation in pressure with flight is important. What should the clinician consider in any patient with airway hemorrhage after the first 48 hours of insertion of a tracheostomy tube? Hemorrhage may occur from the incisional wound if operation is less than 48 hours. Beyond 48 hours, consider tracheoarterial fistula. This requires immediate evaluation by a thoracic surgeon capable of performing an emergency sternotomy for ligation of the innominate artery, because massive hemorrhage often develops after an initial episode of mild to moderate bleeding. When should one suspect the development of tracheoesophageal fistula? The patient will present with cough and shortness of breath about 2 months following the removal of tracheostomy. Recurrent aspirations of esophageal secretions may manifest as nosocomial pneumonia. A tracheoesophageal fistula is related to pressure necrosis by the tube cuff or tube tip and occurs as a complication of tracheostomy in less than 1% of patients. Suspicion of a tracheoesophageal fistula should be pursued by endoscopic evaluation, either by tracheoscopy or bronchoscopy, which can establish the location and extent of the fistula. Is there an optimal time to perform a tracheostomy? Tracheostomies are generally performed at around 10 to 14 days of intubation. RCTs have failed to demonstrate a consistent benefit earlier to this time point. However, select patients with additional considerations such as anticipated prolonged respiratory failure, a difficult airway, or difficulty with airway clearance may benefit from early tracheostomy. The potential benefits of tracheostomy over prolonged translaryngeo intubation includes improved comfort, enhanced ability to communicate, and greater mobility. What are the variations of tracheostomy tubes in the intensive care unit? This includes cuffed versus uncuffed tracheostomy tubes. Cuffed tubes allow inflation to facilitate positive pressure ventilation and maximal airway protection. Uncuffed tubes are appropriate in those with minimal ventilatory support and intact airway protection. Tracheostomy tubes may be fenestrated or unfenestrated. Fenestrated tubes have an additional opening in the posterior portion of the tube to facilitate airflow through the vocal cords. However, these may be obstructed by secretions. Fenestration also promotes the formation of granulation tissues, resulting in bleeding during tracheostomy change and potentially tracheostenosis. A speaking valve may be added to the tracheostomy tube, which occludes the tracheostomy tube opening in exhalation and allows for speaking. It also permits easier swallowing, as the cuff must be deflated. Why do patients aspirate after removal of a tracheostomy tube? Scarring of the stoma site may interfere with the rostrocaudal excursion of the larynx during swallowing, which is necessary for glottic closure. In addition, prolonged diversion of ventilation away from the glottis causes attenuation of the vocal cord adductor response, which is important in aspiration prevention. When should you look for upper airway obstruction after decannulation of a tracheostomy tube? Patients may have upper airway obstruction immediately after decannulation, or obstruction may develop months to years later. Causes of delayed airway obstruction after decannulation include subglottic or tracheostenosis and tracheomalacia. These complications may progress slowly with a gradual narrowing of the airway, leading to exercise-induced dyspnea, which may be ascribed to the patient's underlying respiratory condition. Stridor or dyspnea at rest is generally a late finding, hence a high index of suspicion should be maintained. Late presentations with sudden onset of stridor may result from acute illness, such as bronchitis or pneumonia, that unveils the underlying airway narrowing and may be life-threatening. What is the role for tracheostomy in obstructive sleep apnea? Tracheostomies can be helpful in the obese and non-obese individuals who fail CPAP usage for treatment of OSA. Compared with no treatment, tracheostomies can decrease apnea index, mortality, and sleepiness in individuals with OSA. For further information, kindly refer to the video Tracheostomy. These are my references. Thank you.